and having a conversation. I mean, one of the things that Martin Myers would say is that at least when an AOBP is being done, it isn't talking to the patient or having them talk back. And it is often hard if you're in the office trying to get an automated blood pressure done to keep people from talking, because 5 minutes of silence is sort of an unheard of thing and it's a bear to get through. One of the things that really generates error in the blood pressure measurement is using a cuff that is not adequately sized. As we see a growth in the magnitude of our adult populations, where overweight and obesity are becoming more and more common, you need to be sure that the width, so you take the blood pressure cuff, turn it 90 degrees, that's the width. The width should encircle about 40 to 50% of that mid-arm. So that's one of the keys. And it's one of the more important things because it's got to be long enough on the arm to do the right thing when it comes to taking the blood pressure itself. And these are just examples of the magnitude of sizes, arm sizes that you can see. And the bladder widths vary from newborns to a typical adult thigh cuff, which is 20 centimeters, like 9 inches in length there. So it's important to get the right size cuff. And when you look at what creates errors in the technique, putting the cuff over clothing. We've had people in my division that have gone for a blood pressure check during pregnancy where their blood pressure was taken over a winter coat. So that it happens. A full bladder, I mentioned, conversation and talking, unsupported arm, feet, back, crossed legs, etc. And one of the things that surprises me is that despite what you just heard, and I'm sure you've heard it before, and I bet you $1 to your donut, that if you were asked at a party, oh, is it hard to take blood pressure? Your first thing was like, no, it's the easiest thing in the world. Well, guess what? When I was still vice president of the American Society of Hypertension, Mike Raycott's a brand new vice president of the chronic disease branch at the AMA, asked me what I thought in 2016 was one of the biggest problems in blood pressure. And I said, Mike, very few people measure blood pressure, take the time to measure blood pressure correctly, often because you are just slammed for efficiency in a busy office practice. And he said, no, that can't be true. And I said, check me out. And so we did. We put a booth up at the AMA convention in Chicago in 2016. I'll be brief, I promise. And we had 159 medical students line up because we put out a sign. We'll give you a free iPad if you can do a blood pressure correctly, just one blood pressure correctly. So we had 159 students from 37 states and a bunch of medical schools across the US all signed the consent form, said they could do it. At the end of the convention, we gave away one iPad. We had professional patients grade every medical student that took their blood pressure. And the average number was 11 steps on the form. And the average number of steps done correctly by our medical students who were told in medical school how to check a blood pressure was 4 out of the 11. We sent the manuscript before it was published to academic medicine. That's what deans and curriculum leaders should be reading. And it was rejected without review. We ended up publishing it in the Journal of Clinical Hypertension. And then Jennifer Abbasi, whose name you see on the lower left side from JAMA, called Mike and called me and said, is this really true? And we said, yes, it is. And so she wrote a cute little medical news and perspective, 2-page piece. And I'm just going to leave you with, look at the views there. This is last year, and it's now up to 283,000 views. So 283,000 times someone has come to the JAMA website to look and see what it was that Jennifer wrote about our study. So this is, it's an engaging issue, but it's still a problem getting blood pressures to be done correctly. And these are all the different things that can happen to screw up an oscillometric measurement. And I'm going to just, I finished my brief rant about the technique, but I want to do one brief rant about our beloved FDA. I'm not dinging anybody who works for FDA. I know they're all overworked and underfunded and all the other things. But one of the things you will see, and we're going to see this come up with the Apple Watch in just a minute, is FDA doesn't check devices, medical devices that measure blood pressure, or any device. They stick to blood pressure because that's what I know. They don't check them for accuracy. They only clear them. They don't guarantee validity. And you can come to FDA with a claim of substantial equivalence if you have a predicate device saying that we're using it for the same purpose, measuring blood pressure, and it has pretty similar technological characteristics. And if you can convince FDA, you don't even have to do a validation study. You'll get your 510(k) clearance and you can market the darn thing. And blood pressure devices are a class 2, moderate risk device in the eyes of the FDA. And the reason why is we base blood pressure treatment decisions on the output of these things. And so it is important to have them working correctly. The Institute of Medicine reviewed the FDA's 510(k) clearance process now more than a decade ago and said it should be scrapped. FDA shot back, fund us to a greater degree and we'll be happy to revamp. And here we are 16 or 15 years later, and we're still in the same basic process here. So no improvement there. That led us to do this. One of the things we decided to do was, after talking with folks at AMA and AHA, was to put together a listing of devices that have undergone validation studies in the United States. If you take one particular company's monitor and you market it in the UK and you market it in Canada and you market it in the US and you market it in Peru, it may be the same identical box and innards, but it may have 4 different model numbers because of the way marketing works on different continents. So we started the validatebp.org website with a group of people dedicated to doing reviews of validation. And when you have a device and you want to have it listed on our site as something that has undergone validation studies, you're looking at much of the panel here that both got behind the need for it and also undertakes the actual reviews. We review home, office, ambulatory, and kiosk devices here. So if you're ever curious about out-of-office blood pressure measurements or in-office blood pressure measurements using validated devices, there's your website at the bottom here, validatebp.org. So talk about cuffless for a few minutes here. That fellow in the upper right is George Sturgeon from Athens. And he's sort of the maven of how to do validation studies, among other things. He's maven for in Europe. And so he leads a lot of the efforts on what's called the ISO, the International Standards Organization protocols, to verify that something is reliably reading blood pressure. And so they have had multiple ISO iterations over the years. We're now on Amendment 2. But when the cuffless technology first blossomed, it really rocked the boat because most of the things that we're checking for validation require a mercury cuff or the equivalent on one arm, and then the new device, it's called the investigational device, on the same arm, but you may have to shift cuffs. So you're doing a standard blood pressure measurement with 2 people listening, independent of one another. Hopefully their hearing is good. They're using a Y stethoscope. And then you interpose a device measurement. And then you do the 2 people on the device and the 2 people on the device. And at the end of the day, you have 7 readings because it starts with the device and ends with the device with 3 interspersed human readings. And we have protocols for how much agreement needs to be made in order to say that this device passes validation by one of 2 criteria. Don't worry about getting too much under the hood on that. Just to say we have 2 criterion, but you're seeing at least 6 different items here because the cuffless technologies have really challenged us in terms of how to do validation protocols. And I can tell you, at least at last I looked, we still don't have a protocol in the US for doing these. This is the European stab at getting a protocol together. And if you're curious about it, this is the place to read down here, the Journal of Hypertension. It's a couple of years old now, 2022, I think. And it's worth reading, but it's just not adopted in the US yet. What we have here is a science statement from the American Heart Association, at least telling us where we are in the field. This is from March of this year. That's Jordana Cohen from our shop at Penn, one of the lead authors here in this science review. If you've ever done one of these scientific statements from the American Heart, it is an effort of love, and I'm glad to discuss more about that in the Q&A. This is the background for it. There's a lot of issues with cuffless technologies, not the least of which is the problem is that it's hard to calibrate them, especially since very few of them actually measure blood pressure. What they typically measure is a lot of other things, as we'll see here. And in this science statement, they identified 7 different areas where there's still problems with cuffless technology: standardizing, accuracy, clinical applicability, calibration. My favorite is clinical utility here. What do we do with this data? We have no prospective outcome data based on this, so it's kind of out there right now. But communication, ethical and oversight, and even person and system level considerations for how to deal with storing the data in some kind of usable format. So when we talk about cuffless technologies, we're not talking about one thing. We're talking about a myriad of ways of measuring blood pressure that involve using a sensor of some kind, whether it's an EKG, an impedance cardiogram, a seismo, and a ballistic, and they're different because one measures the low frequency vibrations in the chest cavity. The ballisto measures the shock wave effect on the whole body. Phonocardiograms have a sound input, so you've got to actually have a microphone on the chest. And then there are sensors that measure pulsatility, like the stuff here in the back of a cell phone that can actually measure through that green light that it emits what's happening to pulsatile flow in the skin, especially with a wristwatch. It's a back of the wrist type of skin. There are ultrasound measurements that can pick up flow, and there are impedance plethysmography things and tonometry and all sorts of stuff. When you look at how it works depending on the particular technology. But something about the heart initiates things, whether you use the EKG or the onset of a flow wave from the heart for example, by an impedance cardiogram. And then you measure either the pulse arrival time, that's the PAT down in the center middle, or the pulse transit time. So the pulse arrival time and the pulse transit time, what's the difference? The difference is that thing called the pre-ejection period. Remember when the heart depolarizes and then starts squeezing a couple milliseconds later? There's a thing called the pre-ejection period. So there's a little bit of time when the heart depolarizes and the heart goes, and then it squeezes. And that time may vary. And that's one of the problems using things that rely on pulse arrival time technologies. Then there's a user-derived input, usually in these kind of things, and then device output, which may be a calibrated blood pressure. So your device, when it comes from the left-hand side here, may come with a blood pressure cuff, or you may have to buy one on your own to calibrate it. Or you may have something like an Apple Watch with the hypertension notification feature, which does not calibrate. There's no calibration involved. You just strap the thing on and it looks at flow waves and tells you with a notification. So I want to talk a little bit about that because Mike asked me specifically, because the Apple Watch made a lot of news recently. It got 510K clearance from the FDA, but it was based upon non-blood pressure related technology. Story for another day. It's not been tested outside the 2,229 people involved in Apple's study. And there are issues because it's using the light wave sensor on the back of the watch here, which, for example, can take heart rate pretty well and probably does a somewhat decent job at irregular heart rates. But when you have differences in skin tone, the contact pressure between the watch and your skin, exercise, and some other things, it kind of leads you to wonder about that. So the Apple Watch data was reviewed by Jordy and a bunch of other folks, as you see here in the authorship here. And here's how it was done in terms of submitting to FDA. They did study people. They didn't just claim substantial equivalence alone. They actually did some studies on using home blood pressure in patients who were not diagnosed with hypertension, therefore not on any hypertensive therapy. And they measured for at least 15 days of home blood pressure data. 30 was the maximum period. And they came away with a sensitivity of 41% and a specificity of 92%. And I've often been told that it's kind of like deer in headlights when you see sensitivity and specificity. So let me do it a different way. In people that actually were verified by the home blood pressure to have hypertension, the watch picked it up 41 times, which means it missed it in 59 out of 100 people. In people that didn't have hypertension, the watch said they did 8 times out of 100. So the specificity was 92%, but the sensitivity was 41%. When you're trying to get a screening test together, one of the things psychologically you're willing to sacrifice is specificity. Okay, I'm willing to have, true negatives suffer a little bit in order to get the truly positive ones. So when you look at a blood pressure taken by a regular clinic visit 2 times, like a couple weeks apart, and done well each time, that has about a 70 to a 75% sensitivity of diagnosing hypertension. It ain't 100, but it is 70 to 75. And that's why when you read the fine print on guidelines, when you're diagnosing someone with hypertension and the office is elevated above the 130 or above the 80 or above both, it's strongly recommended to get out of office measurements to verify that you're not dealing with a white coat effect or something else that might be clouding the issue of diagnosing it. But when you look at this is a short article and worth a read. The bottom line here is FDA clearance. So the clearance mechanism is not a certificate of accuracy or a mandate for clinical readiness. That's the take home point. When you look at our 2025 guidelines that came out, at least part of the time they came out was the Hypertension Council meeting last September, in circulation, the cuffless devices earned a 3, which is no benefit, and it's not recommended to use them as things stand now. In my heart of hearts, I'm sure I think they're going to overcome a lot of these obstacles and become useful, but they're not, I don't think, ready for prime time just yet. European Society of Cardiology guidelines, both ESH and ESC write guidelines, a story for another day as well. But what they say at the bottom here is in view of these issues, and there's a whole big paragraph about the issues, none of these cuffless measurement modalities are currently recommended for routine clinical cases. And this guy here, Ramakrishna Mukamala, if you're interested in the science behind the cuffless technologies, that's the guy to read. Writes very well in the area. Ignore his rant down here. It's even worse than mine. So I want to just give you an example of why technique, I'm going to close with this kind of thing here, is so important. And I'm going to use the PREVENT. You'll hear more about PREVENT and what it is in just a few minutes. But this is Sadia Khan from Northwestern and Chiadi and Dumele from Hawkins here. They're kind of the architects, especially Chiadi for the CKM, the cardio, kidney, metabolic stuff. But they're touting the PREVENT here, and I'm going to use the PREVENT for just a mind experiment with you. Let's take a 50-year-old guy who has a systolic blood pressure of 120, and everything else is normal, not on antihypertensives, not hypercholesterolemic, not using statins, GFR is okay, all the other things. When you plug that 50-year-old with a systolic of 120 and vanilla background, you're looking at a 2.4% 10-year total CV risk and almost 16 for 30 years. All well and good. So let's take that 120 and jack it up to 130. And look again. And this is what happens here. Small 10-year risk bump, a little bit more in terms of 30-year risk bump, because 130 is not as good as 120 when it comes to, having that life insurance policy go for a long time. Let's change the age now to what is one of the most significant epidemiologic risk factors for death or other bad stuff, which is age, and let's make it 60 instead of 50, and look at the 120 again. Now we're looking at 5.6% and a 25% 30-year, and then the 120, let's make that 130, and now you can see the differences here. That's why those errors, multiple errors add up, and when you make an error in technique, you're assigning risk to an individual that actually isn't there. So they may be a little scared beyond necessary in terms of the clinical management. So I just want to put out that call out for good technique. It takes a couple extra minutes. Yes, I know that, but it's worth it, I think, in the long run. So these are my thoughts, rounding third base here and getting ready for that last stretch to home plate. This issue with blood pressure measurement is extraordinarily important. In 2010, I think, 2010 or 2011, the World Health Organization designated high blood pressure as the leading non-communicable disease risk in the world, low, middle, and high income countries. Worldwide, it's the single most important thing. And that's for death, and that's also living with what's called a DALY, D-A-L-Y, a disability adjusted life year. So when I have an opportunity to preach to my residents, fellows, and students, I tell them you're not going to do anything more important for public health than to correctly measure and manage an elevated blood pressure. There are a plethora of measurement devices available. If you wander through Eckerd's, Rite Aid, CVS, whatever, your favorite, Walgreens, Amazon, you name it, about 80 to 85% of the oscillometrics you can buy currently have never been subjected, as far as we know, to a validation protocol. So it truly is caveat emptor. ValidateBP.org. I should have put that on my disclosure. So I'm one of the reviewers for Validate BP. They don't pay me, so it's not like I get income from that. It's one of those citizenship things, but it is enlightening to see just the process and the care with which we go through these reviews. FDA clearance of a device, 510K clearance, is not a guarantee of accuracy. And last point, and I just want to go on record saying this, cuffless devices have incredible potential. They can go places that an ABPM and an oscillometric and an aneroid cannot go. And they can do stuff at night, and they can get far more data. You know how many heartbeats you have in a day? Imagine if you were able to take a blood pressure with every one. That'd be 100,000 blood pressures a day. And that's terrific. What amazing amounts of data. What the blazes do we do with it? Because we have yet to do studies to look at that kind of volume of data, making treatment decisions on people. So they have great potential, but there's still a few kinks to iron out, not the least of which is the calibration issues, the maintaining of calibration issues, and dealing with voluminous data when it comes to the output from these devices. I think it's exciting what lies ahead, but I think that the horse is still behind the carriage when it comes to this field. And in order to get that horse out in front, we still have a little bit of work to do. So to quote one of the founders of our illustrious university, Benjamin Franklin, in the upper right there, better to light a candle than to use a wearable cuffless technology, i.e. to curse the darkness. So thank you for listening. I'm going to turn it back to you, Mike, and I'm going to stop sharing at this point. And either I take questions now or you go on. I forget what the agenda is.
Thank you, Ray. Do we have questions in the chat, Benet?
I'm checking. One moment.
And anyone on the call, if you want to speak up, you're more than welcome.
No questions in the chat.
I know we have several prominent clinicians on the call, and we welcome your comments or questions about these issues.
Yeah, I can, it is amazing how popular I think because it's new, the cuffless technologies are. I've had patients come in, especially the one woman, I'll never forget, she came, a young woman, she was a paraganglioma patient with inoperable disease. But she said, I got this new app for my iPhone. And she sticks the thing on her chest and puts her finger over the thing. And the phonocardiogram comes from the microphone in the iPhone, and the little sensors that do the photoplethysmographic measurement on the back measure the arrival of her flow wave in her finger. And honestly, I don't know, she calibrated it. So it turns out it was fairly close to my office pressure. So I was defenseless in terms of dinging that, but it's common and people love this. And there are booths at every meeting now where people are coming to you as if they can Shanghai you at the AHA, ACC, CRT, ESC, ESH, whatever meeting. And there are now a number of cuffless technology booths out there. So it's helpful to be armed. And so that AHA science statement and the little blurb on the Apple Watch, probably useful pubs to at least have skimmed before you go diving head first into this area.
So have you seen a number of patients who, because their watch told them they were now hypertensive, they sought out the clinic?
Not yet, Mike. No, have not. No, I went and I've gone and went emeritus. So the hypertension notification feature is post-dated from my time at Penn. So I'm now 25% and it's all research.
Yeah, but you're a happy dinosaur. Don't worry. Dr. Pradhan, one of our local internal medicine docs, is on the call. Dr. Pradhan, please, you have a comment or question, my friend?
Dr. Thompson, is
I think you're muted, sweetheart.
No, he's out. He's not actually. He's just slow, low volume.
It's awesome presentation. Can you hear me?
Thanks.
Yeah, project.
Yeah, it's awesome presentation, a lot of history. You're right. The patient bringing this voluminous information about blood pressure check and different thing. I asked my patient to bring the cuff blood pressure machine from home. They bring the reading from home. Home readings are great, and then office readings are not. And I scratched my head. What should I treat? The out of home reading, 30 readings, maybe 2 or 3 are high, and the rest readings are normal, i.e., 120, 130.
Yeah.
And talking about medication, talking about the food, we have so many different choices we have, but it still scratched my head. I'm not able to control the blood pressure as I would like to do that. What's your thoughts on that?
So this happens a lot, especially in a referral practice where there's a discrepancy between home and office. Sometimes it's the other way around, but the type of thing you described, where it's high in your office, but they bring in sheafs of well done, presumably, and reasonably well controlled blood pressures from home. So you've got one of two things, maybe more, but at least one of two things present. You've either got someone who has what we call treated white coat hypertension. So they may be on meds, but that doesn't make the white coat effect go away. Or you may have someone who takes blood pressure when they're in the optimal circumstance, writes that one down, takes one, it's not so good. Well, it makes an excuse, and then you end up with some selection bias unless you've got a memory module in the oscillometric monitor that you can tap and go back through the readings to see that there weren't selective entries into a journal of blood pressure readings. What I do in this situation, if I'm not sure, especially if it's someone who's a little older, who may have a little lipid, maybe a little A1C 6.5, something, I do an echocardiogram, and typically I manage to get it paid for. And the reason I do that is that one of the best ways I know of to do, if you will, a biopsy of the body's response to whatever their true blood pressure is the thickness of the left posterior free wall and the interventricular septum. When people have walls that are 9 millimeters, I'm okay with their home readings and I go by that. When people have 13, 14 millimeter walls, their home readings are lying to them. And so that's a circumstance where I would intensify regimen.
Great question. Great answer. Any other questions or comments from anyone?
Dr. Kaplan here. I'm internal medicine physician. I have one quick question. So of the blood pressure digital devices that you have validated, because there's one that's commonly sold at stores around town, and we actually promote them as a home blood pressure device for people to buy, is made by Omron.
Yes.
Was that a company that you validated?
Yes, there are several validated Omron monitors in there. Back in the day, one of the things, Mike talked about waiting for the January issue supplement to Diabetes Care. I did that as well because it had the hypertension management of diabetes. And there were times when the definition of goal blood pressure in the diabetes world was different than the goal blood pressure in the non-diabetic hypertension world. But every October, Consumer Reports would come out with a blood pressure issue. At least that'd be one of the things they would cover in it. And my nurse practitioner and I would both read the article, come in, talk about it, because we would be recommending monitors to patients. And Omron and the A&D monitor were some of the best monitors in the Consumer Report experience. And A&D and Omron are still good monitors to this day, but so are others. I think we have quite a few now on the Validate BP website, but the Omron 5 and 10 series are certainly good monitors. Yes. Awesome. And I want to talk to Dr. Manesh Shah's question here. Somebody is morbidly obese. Can we put the cuff on the forearm instead of the arm? The answer, it's this, how much time do I have, Mike? I don't want to run.
You're okay.
I don't want Dr. Jones to have a heart attack there waiting for his chance to.
This is good stuff.
That's an important question, right?
All right. So the obese arm is a challenge for several reasons. Number one, you may have a cuff that may encircle the arm, but the odds are the width of that cuff is not going to be 50% of that arm. It just
Bladder's
it
not
can't
big
be.
enough.
So you got a problem right off the get-go. You got one of two or three things you can do in order to see what degree of control you have. This is a circumstance where I use either the Omron or the Braun wrist cuff. It's cuffed. It's a cuff device, and we have several of them on the Validate BP website. The thing about anything you do with the wrist, you've got to read the directions. Sometimes the wrist, like the Omron wrist device, you put your finger on your clavicle, the tip of your clavicle here. That's how you know your arm is in position. And the reason that's important is that within the wrist monitor, there is a thing called an inclinometer. It knows that it's in the correct angle, but it doesn't know if the angle is here, here, or here. It's the same angle. So you've got to get the arm in the right place as well as at the right angle to the ground. So wrist monitors are one way you can do that. You can put a cuff on the forearm, and I've done that, but there's one or two tricks that are going to be necessary to have in your bow, in your quiver, a couple of arrows that are useful to have there. Sometimes you can't hear it. It's really hard to hear the radial blood pressure. The trick there is to raise the arm for 10 seconds, drain the arm, and then bring the arm back down and then listen. And usually you hear the Karatkov sounds much more clearly. Or I've had patients where push came to shove, I had to do management of their blood pressure based upon palpating the systolic blood pressure using a forearm cuff. It was the best I could do. And by the way, when I mentioned about the wrist cuffs, some of them, the wrist goes out here on the desktop, straight arm out, not up like this. It's actually lower. So you got to read the directions for how that wrist cuff does its blood pressure magic. But there are a couple of ways around the obese arm. You can use a forearm cuff, you can use a wrist cuff, or you can push comes to shove and you have nothing else. I've done a couple of patients over the years where I just managed the systolic pressure, and often they're older in that circumstance. So the systolic's always the one that's hardest to control anyway. Over.
Any other questions, comments, concerns, complaints?
There is a question in the chat. I've been multitasking, so I hope it hasn't been asked. If someone is morbidly obese, can we put the cuff on the forearm instead of the arm? Hope I didn't miss that.
He just got it. He just got
Okay,
it.
okay, I'm
Yeah.
sorry. I'm
It's
sorry.
already recorded.
I'm multitasking.
So last call, any final questions for Dr. Townsend, who is just a delight to have along with Dr. Jones tonight? Okay, well, Ray, thank you so much. Great job. And if you will, Dr. Jones, go ahead and bring your slides up and let me refresh everyone's memory. You may recall, if you're part of our little world that comes to these programs, we had the privilege of having Dr. Jones talk with us in February of this year as Heart Month. He chairs the 2025, what would be the JNC 10, if you're into that, but the American College of Cardiology, and actually also the the Pharmacy Association and Nursing Association's guidelines on high blood pressure detection, prevention, and management. To refresh your memory, he is from Ole Miss, the University of Mississippi, where he's been for all of his professional life. He started out with his undergraduate work at the Mississippi College and then did his MD degree at the University of Mississippi in Jackson, followed by his internal medicine training there. Basically, he has had an increasing, almost a meteoric rise in leadership, ending up as the previous chancellor of the University of Mississippi. He's currently the professor emeritus and dean emeritus of the School of Medicine at Ole Miss. He served as the American Heart Association national president in 2007. And also, which I think is so notable in his career, he spent several years as a medical missionary at the Community Health Department and Hypertension Clinic at the Wallace Memorial Baptist Hospital in Busan, Korea. Unbelievable humanitarian-centric person who brings a really great practical approach Tonight, he's going to talk with us about the Prevent, that's a brand name, PREVENT, screening calculator to predict, calculate, estimate cardiovascular risk. This whole process, as he's going to tell you about, and I won't steal his thunder, starting with Framingham, and I think you'll be very interested in how it's evolved. So, Dr. Jackson, thank you so much.
All right, guys. So it's so good to be with you again. I enjoyed being with you a few weeks ago, and I didn't hear all of Mike's introductions because despite all those kind things that he said about me and how smart I am, trying to share my screen, I cut myself off and didn't hear the introduction. But I'm sure, Mike, you said nice things about me. Can you hear me now, and can you see my screen?
Yeah, we can. You just need to go to slideshow to make it full screen.
Okay, here we go. All right, I'm going to move you out of the way so I can do that. Okay, there we go.
Just click on slideshow at the top.
I'm doing it now. My computer's not smart enough tonight. Right down here.
You may have to go up to top left slideshow from the beginning. Just a little bit further left. There you go. You're good. Okay, showtime. Yep, looks good.
Can't hear him if he's talking.
You may be muted, Dan. Go back to your desktop.
Say something now, and let's see if we can hear you.
It's still marked as muted.
There we go. We can hear you now. We can hear you now.
No, he's still showing as muted on the display.
Renee can bring the slides up if you want her to do that.
Okay, he's not muted anymore. Can you say something?
If that's his laptop screen, he's not even logged into the meeting anymore.
It's odd because it's not, he's trying to log in, yet his video screen's appearing on the display on the attendees. Dr. Jones, if you hear me, you might consider logging out and then logging back on the Teams and to see if it corrects you.
All right. I think that was an okay. If we can get him back, we can bring up his slides from our side.
Can you hear me?
Yes.
Yes.
I can hear you.
Okay, can you put my slides up and we'll do this?
Can you do that,
Oh, we
Vinay?
can see you now too, as well. Good.
Vinay, can you bring his slides up? It's in the program folder. Or I can do it if you want.
If you have your hands on them, can you grab them? I have to find them.
1 second. I'm getting there. Just stand by. Second.
Like if you can't get it, I can try again from here. I'm just afraid I'm knocking myself off again.
Just a second. I think I'm getting there. Just a second.
Okay.
Getting there. Now let me just go share and we'll be going here. Just a second.
All right. All right, there we go.
We'll get you a full screen. Just 1 second.
Mhm.
Okay, showtime.
All right, here we go. Next slide for me, please. Okay, so most of you are familiar with the book. All I really need to know I learned in kindergarten, and that makes some of us think. Next slide, Mike. That all I really need to know I learned in medical school or nurse practitioner or PA school. And wouldn't it be nice if that were the truth? But my goodness, science changes. So next slide, Mike. What we really need to know is what we learned in medical school or nursing school, and then what we're learning in CME. So Mike asked me to present the PREVENT calculator in a way that was practical for primary care clinicians. And I remind you, if it didn't hit you when Mike introduced me, that I am a primary care clinician. And I learned about the PREVENT risk calculator only a few months ago. And here is my simple view of it that I share with other primary care clinicians primarily. This is a calculator that assists you in decision making about medications for primary prevention of the risk factors for cardiovascular disease. It's as simple as that. You can use it for other things. You can use it to counsel a patient about what their overall risk is, but it was really designed to help you decide, does the patient need lifestyle plus medicine or only lifestyle to manage their problem with diabetes, with high blood pressure, and dyslipidemia? Next slide, Mike. So why is it important to primary care? The cardiovascular disease guidelines are important because they are the leading cause of morbidity and mortality. What are those guidelines? The blood pressure guideline, the lipid guideline, and the diabetes guidelines. And because obesity in your part of the country and my part of the country is related to all three of these, we need to be keeping up with the obesity guidelines as well. Keeping in mind that when we talk about cardiovascular disease, our clinicians who are specialists are treating at the end stage of disease But those of us who have a chance to prevent cardiovascular disease, to help people have cardiovascular health, are on the front line, the primary care clinicians. It's not the cardiologist, it's not the nephrologist, it's not the endocrinologist, it's the primary care clinicians who are providing the guidance for the patients and for the prescribing of the medications. And the Prevent Calculator is simply a tool for you to help you with an individual patient to know, do they need medication to lower their blood pressure, to lower their lipids, to manage their diabetes. Next slide, Mike. So just a few issues to think about. The calculation of risk is easy. It's very much like the other risk calculators that you've used in the past. The electronic medical record integration is coming and will make it easier even for you. Prevent is an important tool for primary prevention, and thus it's an important tool for primary care. Making decisions around blood pressure is relatively easy. If you've read the lipid guidelines that have been out for a few weeks, you recognize that lipid management decision-making around risk is a little more complex than making decisions around risk for blood pressure. But we'll talk about it. And again, this is not rocket science. It's things that you can manage in every patient that's in front of you in your office tomorrow. All right, next slide, Mike. So as Mike said, there is a history for the use of calculators to determine risk. We began back in the 1950s with data from the Framingham study, and that was the only data that we had that helped us to understand what's the relationship between a blood pressure and a lipid level in somebody who's in their 40s and 50s, and when they have a heart attack or a stroke. We learned it all from Framingham, and then a few years ago, the pooled cohort equation came around, and then just in the last year or so, the Prevent Calculator. Let's look at the history of that, Mike. Next slide. So when Framingham was done, it was based on those 5,000 or so participants in the original Framingham cohort. So we had evidence from about 5,000 white people living in Framingham, Massachusetts, to help us understand how to calculate risk. The pooled cohort equation a few years ago included 25,000 patients from a number of longitudinal cardiovascular disease studies like MESA and Cardia and the Jackson Heart Study. And we had a lot more information on a more diverse set of populations. The Prevent Calculator was necessary because of the changing risk and disease relationship, and because the digital world allowed us to have 3,200,000 patient records in this calculation. So just imagine the difference in the accuracy for determining risk for your patients between a database of 5,000 or 25,000 or 3.2 million patients. The Prevent Calculator is a good addition to the tools that you have for helping your patients understand risk and to help you understand when to prescribe a medication for their cardiovascular risk factors. Next slide, Mike. So the Prevent Calculator is contemporary. It helps us to calculate risk not just from age 40, like the pooled cohort equation, but from age 30. Now, this is an important issue here, and you probably have read a lot about the social determinants of health, and the fact that the Prevent Calculator is the first calculator not to use race as a risk factor for determining risk for cardiovascular disease. It doesn't mean race is not important. It was just determined that actually putting in a zip code, the zip code of the person, was a more reliable predictor than the self-determined race based on skin color. So it's an amazing thing that it's true, but it is absolutely true. So you won't find race in the calculator, but you'll find the opportunity for putting in the zip code. And then as this calculator matures and as our medical records mature in using social determinants of health, there'll be other things to add in. Importantly, it includes heart failure as a endpoint for the prediction. And of course, heart failure now is the most common way people with cardiovascular disease are dying or having end-stage disease. There's also a major focus on cardiovascular kidney metabolic disease. Again, that broad spectrum that so many Americans have leading to the end stage of cardiovascular disease. Next slide, Mike. So here are the things that go into the calculator. You'll see, looks a whole lot like what you've been doing for the pooled cohort equation. Gender and age, systolic blood pressure, not diastolic blood pressure, but systolic is so much more predictive. Total cholesterol and HDL, not because those are the most important, but because they help you calculate LDL cholesterol, which is what is really the risk factor that we're looking at here. But in your lab and my lab, most of the time, what is reported out is total cholesterol and HDL and triglycerides, and we can calculate non-HDL cholesterol or LDL cholesterol. The EGFR, the glomerular filtration rate, calculated primarily from your serum creatinine. BMI, yes, there are better measures of adiposity than BMI, but not easily available in most clinical records. BMI is still a very good predictor about whether someone has obesity or not. And then the next four of these are just yes, no questions. Do they have diabetes? Yes, no. Are they smokers? Yes or no. Do they take lipid medication or blood pressure medication? Yes or no. And then there are three optional things that can be added if they're available to you. When I talked to you last about evaluating a patient for hypertension, I told you that it is now recommended that everyone with hypertension have a urine albumin creatinine ratio. It's not mandatory for calculating the prevent risk for the patient, but if you have it in the record, it's useful to use. It gives you a more defined risk prediction. Hemoglobin A1C and zip code the same. You'll have that for many of your patients. Next slide, Mike. So the prevent calculator is used in the description of risk in the 2025 hypertension management guideline and the 2026 lipid management guideline. Now here's something important. I'm going to talk to you about thresholds in just a moment, but it's important that you not use the pooled cohort equation and then use the recommendations from the 25 hypertension guideline and the 26 lipid guideline and the thresholds that are recommended there. You can't use the pooled cohort equation for that. You need to use the new prevent calculator. Now, as I've just shown you, it's not hard. It's not that different, but you need to be using the prevent risk calculator with it. Next slide, Mike. So here are the thresholds. Now, the thresholds simply describe, based on clinical trials, randomized controlled clinical trials, the benefit risk ratio. Where does benefit outdo risk in managing the patient in terms of using medication? Simple for blood pressure management, 7.5%. You calculate the risk score for the 10-year risk score for your patient and use that 7.5% as the decision point. For the lipid management guideline, they give four classes of lipid levels: low, and less than 3% of risk. Low risk is less than 3%, borderline 3 to 5%, intermediate 5 to 10, and high greater than 10%. Now let's look at how these are applied in those two guidelines, Mike. So if you were on the call a few weeks ago, I showed you this algorithm for making decisions around blood pressure. So you begin with if the patient has high blood pressure, that means they have a systolic of 130 or above. So the first question is the systolic above 140 or the diastolic above 90? If the answer is yes, start medicines. Does the patient have pre-existing clinical cardiovascular disease? If it's yes, regardless of the blood pressure, if it's above 130, you start medications. Does the patient have diabetes or chronic kidney disease? If the answer is yes, you start medications. If all of those are no, then you use the prevent calculator. And if the 10-year risk is greater than 7.5%, you go ahead and begin the medication. If the answer is no to this, if their 10-year calculated risk based on prevent is less than 7.5%, then that patient is a candidate for 3 to 6 months of lifestyle therapy to see if they can get that systolic blood pressure below 130 and their diastolic below 80. If they do that, then you can continue to use lifestyle therapy for management of the patient. If after 3 to 6 months, the blood pressure is above 130 or above 80, then it's time to start the medication on that patient as well. All right. Mike, the next one, if you will. All right. This one is the algorithm for lipids. I'm going to take a simplified approach to it. There are a lot of risk enhancers mentioned in the lipid guideline. I'll encourage you to take the time to look at those. A lot of it is based on inflammatory disease, but let's start on the simple things. If the risk is low, if the prevent calculation is below 3%, they basically are a candidate for lifestyle therapy and no medication. If they have a borderline risk, then you consider the risk enhancers. If you're still not sure, they might be a candidate for coronary artery calcium, and you make decisions based on the results of those. They may or may not be candidates for lipid therapy. Again, we're looking at the risk-benefit ratio. The statins and other lipid-lowering classes of drugs are a little bit more risky than the blood pressure drugs, and so that decision around using drugs or not is a little bit more important decision for your patients. Basically, for above 5%, 5 to 10, and greater than 10, almost all of those patients eventually will get on medication for lowering their cholesterol. Next slide, Mike. So here are the key issues. Calculation of risk is easy. EMR integration is coming. Prevent is an important tool for primary prevention, thus for primary care. Blood pressure decision making is not so hard. Lipid management is a little more complex, but not out of your range to be able to do. Next slide, Mike, and we'll look. Here's where you can find the calculator. Yes, my little pitch for primary care. Our ultimate goal in primary care is not disease modulation, but it is health. Try to intervene with the patient before they get sick, before they have vascular disease. Next slide, Mike. And so I missed somewhere. Where do you find the calculator? Mike, this is the old
We didn't
set.
have your last slides you put in.
Yeah,
You
yep.
added
So
that slide after you sent the deck. So I would
Yep.
just tell them, and we can follow that up, sending it
Yep.
out where it is.
basically, it's at the AHA website. If you simply do a search on the Prevent Risk Calculator, it'll take you right to it. All right, guys, thanks so much, and I'm happy for questions or any discussion that you might have.
We have questions for Dr. Jones from anyone in the chat or any of our online folks tonight?
Dr. Jones, this is wonderful. Can you hear me?
Yes,
Yeah.
got you.
Yeah, it's a wonderful talk. Thank you. I've been using the Prevent Calculator after you mentioned that last meeting. I've been pulling out from the, just simply you go to AHA website, you can easily pull out. I was not able to use for the patient who had BMI more than 40.
Yeah.
What was the reason behind why the BMI was cut in 39.9?
Yeah, there are not enough patients to put into the database to make an accurate prediction, but you can take that the prediction for the 39.9 and just know that it's going to be worse than that. But there's not enough of those patients in the database to actually give an accurate prediction.
Yeah, and one other thing I would like to mention that to everybody, there is a CPT code for once a year you can do the calculate, and as a primary care physician you can charge for that. So that is important for the finances revenue.
Indeed, thanks for mentioning that. Yeah, it's great.
Is that
Thank
part
you.
of the wellness visit, Dr. Padala?
Yes, part of once a year you can do that, and it takes 3 to 5 minutes. I will print out and hand it to the patient. I like the Prevent because it gives you 10 years and 30 years. So a person who is 40 years old, he's thinking about like, I don't take the medicine now, but then he will end up with disease if it doesn't intervene when you're 70. So that really helps. So thank you for bringing that out.
I love the questions. Anything in the chat, Renee?
No questions in the chat. I
Dr.
do
Jones, go ahead. I'm sorry. Excuse me.
just want everyone to know that I have dropped in the survey in the chat for them with the QR code and the link.
Thanks.
Hello, Dr. Jones. Can you hear me?
Yes, please. Go ahead.
Yes, sir. So I'm Minesh. I'm one of the primary care. And in the prevent calculator, you mentioned diabetes. But my understanding is if you have diabetes, you already have equivalent of coronary artery disease. So why it has used to prevent it? Because they already had like an event. And the second question is, can you mention something about a CT calcium score and how do we use that in the practice? Thank you.
Yeah. So the first question, you're right. If the patient has diabetes, this risk calculator is not as useful. It can be useful in helping them to understand the degree of risk that they have, but it's not going to help you in decision making about medicines. If they have diabetes, you're certainly going to have them on a blood pressure drug if their blood pressure is above 130 systolic, and you're certainly going to have them on lipid lowering drugs if their LDL cholesterol is elevated above 70 or so. And so it's not useful in decision making about medications, but it can be a useful tool in motivating a patient to use those medicines appropriately to get their risk lower. A diabetic patient, though the risk is higher than in other patients, managing their risk factors can indeed reduce their risk, give them more years of a healthy life. So it's useful for that. In terms of the coronary calcium score, the coronary calcium is a tiebreaker in patients who have intermediate levels of lipid. We don't use it in the blood pressure guideline recommendations because so many people are eligible for antihypertensive medications just simply based on their blood pressure, and we don't use it as a tiebreaker. But the lipid guideline uses it as a tiebreaker, and there are various ways to interpret coronary calcium. In some of the interpretations, if you have any coronary calcium at all, then it tilts you toward using lipid therapy. And then there is some room for judgment about the coronary artery calcium score, and there's a long discourse that in the lipid guideline. I'm not a lipid expert, so I won't try to talk too much about the coronary calcium and the lipid scores.
Thanks. Other questions or comments? Dr. Jones, do you know if which specific EMR system Heart may be talking to for integration yet, or is that known yet?
Yeah, it's not done. The American Heart Association is working hard with Epic to get it in Epic, but I think probably once it's done in Epic, it will be done in almost all the other systems. Right. Epic is the big boy that will fall first, and yeah, but I think certainly the Heart Association wants it at every clinician's desk when they're seeing the patient.
Good idea. Other questions, comments? I'll just report to everyone on the call tonight. On August 27th, that's the last Thursday in August, we will have the Dr. Jones's parallel, the chairperson of the 2026 American Heart Lipid Guidelines, Dr. Roger Blumenthal from Johns Hopkins. He will be presenting those guidelines to you, to our local audience, that last Thursday in August. And we'll send out a notice about that. Because that again, it parallels the periodic, if you will, Joint National Committee reports on high blood pressure management. It's a result of the previous National High Blood Pressure Cholesterol Education Program, which began in 1982, and followed on because the high blood pressure education program was so successful in increasing awareness and getting patients started on medicines. We're ahead of time tonight. Any final questions before we let these two extremely scholarly physicians leave us? I know Dr. Townsend, I think, is still on the call if you have a question. Final call. Any last comments? Okay, well, let me thank everybody for joining us. Thanks to Ray Townsend and Dr. Dan Jones. They are two of the very, very best in the business of blood pressure management, prevention. It's just a delight and really privilege to have them on the call. I remind you that next Thursday night, same time, same station, we will have the 2026 American Diabetes Association guidelines for the medical management of diabetic patients with Dr. Stanton from the University of Virginia and one of our own, Dr. Eric O'Neill, assisting him, one of our residents, with a case presentation that Dr. Stanton will basically springboard from. So that being said, thanks for being on the call. Thanks to Pam Cornell and to Vinay Mayo for facilitating everything tonight. It's a privilege to have you join us, and we look forward to seeing you in a week. Have a great evening. Bye-bye. Good night.